Entonces presento al doctor Nicolás Mouawad, que va a hablar sobre lo que es el tratamiento o la nueva técnica que se llama el transcarotídeo. El doctor Mouawad es un cirujano vascular con formación endovascular, que es el modelo de cirujano que en el campo de la cirugía vascular nosotros estamos
Okay.
buscando en Latinoamérica. Y bueno, justamente esta técnica me parece que habla de lo que debe ser como profesional, porque justamente la técnica de TCAR lo que busca es la combinación de los dos mundos, la cirugía convencional versus los procedimientos mínimamente invasivos. Lo toma Guay, es el jefe de cirugía vascular y endovascular de McLaren Health System Bay Region en Detroit, Michigan. Así que, doctor Mouawad, te dejo la presentación a usted. Nicolás.
Right. Okay. Good morning, everybody. It's great to be here. I just want to say thank you very much to the program committee and to the Congress, or General Surgery Congress of Argentina, Dr. Pagliari, Dr. Sansini for this invitation. And I also want to say thank you to my good friend, Dr. Juan Pardo, as well for this invitation. We were hoping to have a live case for you all today for deep venous thrombosis, but unfortunately, some issues with the live streaming company and some United States corporate compliance and regulatory effects. So I apologize for that. We're hoping to be able to host you sometime again in the very, very near future. As an aside, we're going to talk today about minimally invasive carotid revascularization and the use of TCAR. My name is Nick Mouawad. I'm the Chief of Vascular and Endovascular Surgery at McLaren Health System here in Michigan and the Chair of Cardiovascular Research. So thank you very much again for your attention. Here are my relevant disclosures. And really, we're just going to start talking initially about the difference between carotid end arterectomy, excuse me, carotid end arterectomy and carotid artery stenting. It should be very well known as we know the first carotid end arterectomy was performed back in 1953 by Dr. Michael DeBakey, but it was Argentina's own Dr. Juan Perotti who carried out the first study on neuroprotection of the carotid artery during endovascular revascularization back in 1998. His studies initially focused on determining embolization rates to the brain during CEA using transcranial Doppler. Really, the same concept, again, was to consider flow reversal. The first flow reversal system, in fact, was designed by Dr. Perotti and tested by Dr. Bates. Initially, the concept was of continuous passive aspiration through a side port, which was created and allowed for flow reversal, which was confirmed by contralateral carotid angiography. To the screen left, you can see the traditional carotid end arterectomy, which is the overwhelming majority of procedures that are performed. Low 30-day stroke risk, and although evidence of adverse events. To the screen right, around 15% of procedures are performed via carotid artery stenting. So a lower adverse event rate because of the minimally invasive nature, but at the time, a concern for a higher 30-day stroke risk. So this is concerning because the point of carotid revascularization is to decrease your chance of stroke. So we want to have the slowest stroke rate possible. As you can see, a variety of studies were completed, including CREST, SAPPHIRE, ACT, and so forth, demonstrating protection after stent placement. With CREST in particular, the 30-day stroke rate was around double for carotid artery stenting as compared to CEA 4.1 to 2.3. A variety of these tests can also be seen in trials to the screen right, demonstrating, again, stroke protection after stent placement, but an increase in stroke events. The safety and durability of stenting is very important to discuss. And really, the major problem is being able to deliver the stent to the site of the lesion. That requires access, usually in the femoral position, traversing the aortic segment to the arch, getting through the brachiocephalic or common carotid segment, and ultimately crossing the lesion. And these areas, with the manipulation of the catheter and the wire, can be quite dangerous. This is actually a paper from 2017 where very interesting and complex methods of delivering a stable platform were considered. Here, for complex type 3 arches, coming from the right brachial, doing a snare technique, coming from the transfemoral segment, and then basically delivering a stable platform can help create that. I even wrote a comment about this back in 2017, showing that establishing a stable platform is difficult in hostile arch anatomies. And so therefore something easier or safer was necessary. We discuss multiple times the CREST data. We always want to know about that because it compared carotid revascularization versus endovascular stenting. And after the first 30 days, the event rates were very similar. And this is now with the recent data up to 10 years. So the goal is to combine low stroke rates with the benefits of a less invasive procedure for carotid revascularization in patients that are complicated. This is where the concept of TCAR, or transcarotid artery revascularization, came through. Again, it offers a minimally invasive approach with a small incision in the supraclavicular region, avoids manipulation through the aortic arch, and therefore disallows or decreases the chance of embolizing through your access, avoids cranial nerves due to the small incision, and then ultimately develops a high flow rate neuroprotection type system. Really, when you think about this in the past, after Dr. Parodi's segments for neuroprotection, Dr. Criado also ultimately did that in the United States with use of the common carotid artery and flow reversal through the jugular vein, all the same location surgically. So the goal here is to basically have an accurate placement of the stent and combining surgical principles with use of endovascular minimally invasive technology. The evolution of carotid disease, as we discussed, started primarily back in 1953, moving to transfemoral stenting, and then ultimately with the concept of TCAR, or transcarotid artery revascularization, with a variety of studies, including Roadster and Roadster 2. Important to note that, generally speaking, most of the studies on transcarotid or carotid stenting were performed in high-risk patients, so patients generally otherwise not suitable for CEA. And despite using them in high-risk patients, the data has been very compelling. So the goal is to really match the patient with the procedure. If the patient has a low bifurcation, there's a significant amount of calcium disallowing appropriate stent expansion, or other concerns, then CEA may be preferable. However, if the lesion is very high, behind the mandible, hostile neck, reoperative site, previous nerve injury, and so forth, there's a consideration that a stent may do better. And why not avoid navigating the arch, navigating the severe stenosis of the carotid lesion if you can do it through a transcervical approach? Let the data speak for itself. As we can see here to the screen left, these were the initial studies that were done primarily in high-risk patients. I draw your attention to Roadster 2, a stroke rate of 0.6% on intention per protocol for any carotid intervention, again, in patients considered high risk. This is per protocol, excuse me, not intention to treat. Lowest stroke rate demonstrated in any study, particularly in those patients that are considered high risk. The VQI data set is very specific for vascular outcomes, and again, they were similar between the two. To the screen right, you can see here patients that are considered standard risk, and again, equivalent to CEA and better than transfemoral CAS, primarily again due to navigation of the stent and the wire to the lesion that you're considered to want to treat. Furthermore, a study in 2021 demonstrates that TCAR done at centers with higher volume have demonstrated better outcomes. You can see the overall rates of major adverse cardiovascular events were similar between TCAR and CEA. However, there's a 10% risk reduction of major adverse cardiovascular events for all carotid interventions in centers that have consideration for alternative treatment pathways such as TCAR in addition to CEA. You can see here to the screen left, the CEA, really the same surgical principles, but placing a less invasive consideration. So the carotid is, of course, exposed, and you can see here back bleeding of the internal carotid artery to flush out any debris and make sure that nothing goes to the level of the brain. To the screen right, this is the consideration for TCAR with the placement of a sheath, and we'll go through this in a couple of slides. Ultimately, having flow reversal, removing or sucking the blood down, placing it through a filter, disallowing cephalad flow, and protecting the brain from any concerns of embolization or plaque debris. Not that vascular surgery is a cosmetic type surgery, but also there's an opportunity to have a more cosmetic incision, less invasive and smaller. There is, of course, a reduced rate of cranial nerve injury because the formal dissection of the vagus nerve within the carotid sheath is not necessary. To the screen right, you can see it can even be performed with local anesthesia, just as a carotid endarterectomy can be performed. But again, these are evidence of small incisions for carotid repair with a very, very low rate of cranial nerve injury. There are some patients of mine that have undergone TCAR. I'm a very big fan of the transverse cervical incision just in the supraclavicular fossa between the heads of the sternocleidomastoid. Here is a patient who in fact had a previous left carotid endarterectomy years in the past and had a recurrence, and we ended up treating that with a left TCAR. So you can see both these incisions that were performed in the same patient, and you can compare the two from a minimally invasive and almost a cosmetic perspective. It actually hides underneath the collarbone. So more importantly than all that is the protection from stroke. So in-hospital outcomes are similar between stroke and death. However, the benefits of TCAR or a minimally invasive option is less risk of myocardial infarction, particularly if the procedures are done with sedation, local anesthesia, less risk of cranial nerve injury, of course, because of the less risk of dissection, less time in the OR, shorter length of stay, and less risk of bleeding requiring intervention due to the small access site of the common carotid artery. Well, how many do you need to do to be good at this, if you will? Kashyap and colleagues did a study on this back in 2020, looking at the outcomes and what makes somebody minimally invasive efficient and proficient. And you can see to the screen left that the major outcomes were equivalent no matter the level of experience of the operator. So whether there were novice 1 to 5 cases, intermediate 6 to 20, advanced, and experts, the major outcomes, which were stroke, death, and MI, and the composite outcome of stroke, death, and MI were equivalent between the levels of experience. Around 15 procedures were considered to make you proficient, so that you're comfortable with it. To the screen right, you can see that the more experienced you are, the more efficient you become. And that number was around 20 based on the paper from Kashyap. So your operative time decreases, your use of fluoroscopy, flow reversal as well decrease the more procedures you have done as you become more expert. But again, from the point of view of major outcomes, these were statistically equivalent regardless of your level of expertise. We generally do ours with general anesthesia. However, you can do them with local or regional, would have excellent outcomes. Again, the goal here would be to have lower morbidity or mortality because of the lack of general anesthesia. And again, just to show again, the consideration here is primarily myocardial infarction and cranial nerve injury when you do an open CA. And this is generally attributed due to the use of general anesthesia and cardiovascular changes, particularly when induction of anesthesia. To the screen right, of course, it has to do with surgery. So again, the type of patients we see that have significant, what would be considered high risk, make it challenging for a carotid endarterectomy due to exposure and previous neck surgery. Here's another type of a patient of ours that have severe cervical neck fusion, makes it challenging to be able to move the neck, and sometimes consideration for a minimally invasive technique would be preferable. I'd like to show you all a case. Again, we use a lot of our streaming. Unfortunately, this company, I said, is no longer with us as of last week, but we do a lot of these live streaming cases. And I'd like to just show you one of our cases for a TCAR and a patient here who had a previous right-sided intervention. You can actually see the incision marked on the right side of the neck over here. Also had a contralateral nerve palsy, making her a very high risk for surgery, very challenging. Her lesion was high, which I'll show you on the angiogram. So the procedure starts with transverse incision at the base of the clavicle. We look for the sternal head and the clavicular head, and in between the two, the goal is to identify the carotid sheath. You can see here using Wheatlander retractors that you can identify the vagus nerve actually is there, and more medial is the right common carotid artery that I'm actually picking up there right now. At this point, the goal is to control it with the use of a vessel loop. I prefer that because I think there is more control and you can kind of navigate it more so than the use of a clamp. So at this point, I'm placing a vessel loop around the right common carotid artery in anticipation for proximal control. You really don't need distal control of the vessel because everything is exposed for you quite nicely. Once this is ultimately performed, and again, you can see the previous incision here. This is the angle of the mandible, if you can see my mouse. And so really we're quite low in the neck. I now place a 5-0 polypropylene suture as a U-stitch in anticipation for closure at the end, because we're going to place a relatively an 8 French sheath. So I pre-stitch this so that we're ready. And this is placed on the common carotid artery in the subadventitial plane. That's now ready. At this point, we use a micro introducer kit. This is basically accessed right in between our purse string suture. My assistant is holding back the carotid there with the vessel loop to give me some backward tension. We use an 018 wire, and I'm going to show you here on this 018 wire, there is a kind of a gray area there with a mouse. You can see it. At that point, it's 3 centimeters, a little bit more, it's 5 centimeters, and that allows us to know where exactly the wire is going to be. So we basically place this 018 wire into the carotid after ensuring, of course, the patient is systemically anticoagulated with heparin, and you have an ACT over 250. So once that's done, we place our 4 French micro sheath, and this is basically placed over the 018 wire. The sheath is going to ultimately be advanced in. And again, we can do this without fluoro because we just have a couple of centimeters in to be able to get access into the common carotid artery. The wire and the dilator are ultimately removed. There is back bleeding that you can see here. And at this point, we do a contrast injection. And you can see here the carotid angiogram demonstrates a terrible looking carotid. You can see high-grade stenosis, almost suboccluded. The internal is patent, of course, but the external seems occluded, nothing more cephalite. More importantly, you can see how it's very high up in the neck, so almost behind the mandible, making it very challenging to be able to do this from a surgical perspective, again, given the fact that she has a contralateral nerve palsy and a relatively short neck. So at this point, we place an 035 wire, and this is now the en route 8 French arterial sheath. This is then placed over the 035 wire under direct fluoroscopic visualization because we want to make sure the wire does not engage the carotid lesion. So that's passed slowly. Once that's placed, again, at this point, I secure the sheath, and you can see this here at one point. I secure the sheath with some suture, so it's a stable platform. And once we're happy with that, we can start our plan to basically start reversed flow and ultimately our procedure. So here, again, I'm securing that. We back bleed to make sure there's no air, of course. We don't want any air in the circuit. And this is the neuroprotective system, the NPS. We place it into the arterial. Now you can see the back bleeding. We go from low to high, and you can see the flow of blood now coming back here. And that's now reverse flow. It's coming from the arterial system, and we attach it there into the common femoral vein on the contralateral side. And now you can see that there is reverse flow. Now the brain is technically protected in the sense of passive reverse flow. We're happy with our platform, and now we can start taking our pictures. Usually I tend to mag up, and then we can see how we're going to go ahead and cross the lesion. So look, with my left hand, I'm pushing the little button, because if I don't push it, all the contrast I'm pushing will get sucked out because of the reverse flow. So you have to stop the system to make sure there's antegrade flow so you can see the angiogram. So again, at this point, you can see the high-grade lesion. We have reverse flow. I'm getting ready to cross this lesion, which is going to be relatively challenging given the very small path. We place, oh, not sure what happened there. Not really sure what happened there. Let me try that again. Sorry about that. Sure. Okay. Let's go back to that. I apologize. I'm not really sure why it stopped there, but at this point, the carotid is clamped. Now we have active reverse flow, so we have to confirm that. You can see to the screen right that there's active reverse flow, and so now our carotid is protected. At this point, we advanced our 014 wire, and the goal is to cross the lesion. Now we're comfortable doing this because the brain is protected with the active reverse flow and the carotid being clamped. And so now the goal is to cross the lesion. We can be aggressive because there is reverse flow and anything is not antegrade for us. So with some difficulty, I was able to cross the carotid. We confirm that we're in the true lumen, not in a dissection plane, and of course, confirm that we're in the internal carotid artery, which is mandatory, of course. Following this, you can select a balloon. I tend to be relatively aggressive using a 5.5 millimeter or 6 millimeter balloon to pre-dilate the lesion. You can see again here the significant disease, again, high lesion, redo, contralateral nerve issue. And at this point, with the balloon being advanced, we go ahead and be relatively aggressive about balloon angioplasty of the carotid. We take a look at the heart rate to make sure there's no bradycardia. We'll give usually 0.4 milligrams of glycopyrrolate first, and then ultimately, once that's done, at this point, we can select our stent. There's a variety of sizes. They are not tapered stents, but at this point, we select the stent, and it is sized according to the common carotid artery proximally. So the stent is advanced over the wire in the appropriate position. Following this, it's a pin and pull technique. And at this point, you can see that going ahead and pulling, pin and pull, coming back to the screen right, the stent is really deployed in appropriate positioning. And ultimately, this is then completed. The decision to post-dilate is a personal preference. We did not use to post-dilate much with transfemoral stenting due to increased risks of hemodynamic issues and stroke or neurologic concerns. But now with TCAR, we're pretty aggressive about that. And this is a completed procedure now with opening up of the severe carotid lesion, and ultimately flow is restored. You can see, in fact, that the internal carotid artery, the external carotid artery is actually filling as well. And even though there's a little bit of a difference here, there's a little bit of vasospasm, that ultimately will end up being fine. The goal is to make sure you have this stent sized appropriately to the common carotid artery proximal. So that's a minimally invasive method of managing these patients. Just to show you another quick one, and I won't go through all the specifics, but to see the challenging part. 57-year-old female with symptomatic high-grade right ICA stenosis, has right hemispheric symptoms with left arm weakness and left leg weakness. Morbidly obese, so 396 pounds. I don't know what that is in kilos, probably almost 180, 200 kilos, something like that. Respiratory insufficiency on home oxygen, pulmonary hypertension, heart failure, neck immobility, and coronary artery disease. And you can see here her medications to the screen left, and then, of course, an ex-smoker to the screen right. Really, the plan was to do a carotid end arterectomy many years in the past, as there were no other options. But the cardiology colleagues and the pulmonary respiratory colleagues would not clear her for surgery, understandably. On repeat evaluation a year later, cardiology and pulmonary said that she could undergo surgery because she's as good as she could, but anesthesia said no. Ultimately, she became symptomatic with her high-grade stenosis, and since TCAR was available, I recommended that because I did not think we could do a carotid end arterectomy on this lady. So you can see this is the SCOUT film here, the things that we're dealing with in the US. So I'll show the CT scan. Again, a very large patient. You can see very deep carotid on the right side, very, very deep carotid, making it very challenging. So there are 92 millimeters to the carotid, making it very challenging ultimately to be able to expose that safely and effectively. This is it again on still image And you can see here in a coronal image, almost 12. So that makes it very, very hard. So the goal here was to do the procedure with TCAR and deliver a stable platform, if at all, because exposing the whole vessel would have been very challenging. And again, she's symptomatic and young. It was not ideal to intubate her, but for respiratory protection, we felt this was the safest thing to do. So you can see here the case. In order for it, we had to move some of the stuff because we had to basically place a femoral sheath and an arterial line. And so the left great saphenous vein was accessed because the common femoral vein was too deep. We almost had to use a spinal needle. And then in a similar fashion, transverse incision, self-retaining retractors, use the stitch, the pre-delivery stitch, excuse me. And ultimately, and fortunately, the disease was confined only to the internal carotid artery, but it was behind the mandible, as you can see here, making it very challenging again for us to be able to do this in an open fashion. So since the disease was confined to the internal, I was able to engage the external carotid artery. This allowed us to have a stable platform, placed our 8 French arterial sheath, started the neuroprotection system with a common femoral vein, and then pre-dilated the lesion. You can see here with a 5.5 millimeter balloon, and then ultimately placed a stent to open that up, and then cage the remainder of the disease. Flow reversal time was 6 minutes, and this was what it was when we were completed. Again, you can see the large veins on the anterior chest wall. So this is what we got in the filter once we were completed. So this is all suction back in the reverse flow or neuroprotection system. And again, fortunately, none of this went to the brain, which would be very concerning to sustain a cerebrovascular accident or a neurologic issue. So really, in short, I showed you, the technique of this. There's advantages to open end arterectomy and advantages to minimally invasive transcarotid revascularization. With all things being equal, you can use one as necessary based on the type of patients you see. Again, nowadays, it is actually approved for standard risk patients and not just high risk, even though initially carotid artery stenting was primarily relegated to high-risk patients. So clinical trial data shows excellent outcomes with TCAR, particularly for new operators and those are learning to try to do this. It's important to remain similar to treatment protocols and do it for the appropriate indication. And of course, there's a patient preference factor as well. So in summary, I again want to thank you all very, very much. I apologize we couldn't do this live and in person, and I hope to be able to see you all soon at some point. Thank you so much for your attention, and good morning, everybody.
Thank you so much, Dr. Mouawad, for your excellent presentation. Any questions from the audience? We don't have questions, Dr. Mouawad, from here. Just I want to highlight the concept. Do you think now or in the future, TCAR would be better when you compare with conventional endarterectomy?
I think that's a very difficult question, Juan. It's a very difficult question. The biggest concern with stenting, regardless of the type, the way you do it, is the durability. And I don't think we have the answer yet. We know that carotid end arterectomy is very durable, lasts 40, 50 years and so forth. We just don't know that with stenting. I do believe that patients are becoming sicker and are living longer. So I do believe there is definitely an option for stenting. And if so, I think the transcarotid method has a better risk profile for the management of those patients. So I don't think it's going to go away. I don't think it's going to go away, but I think the biggest concern is going to be durability.
All right. Do you discharge the patient the same day?
They don't let us do that. They have to spend one night in the hospital. That's the rule. But do I think patients could go home the same day? Probably. I think so, but that's not something that we can do yet based on insurance and rules and all that. They have to have what we call one midnight stay. So they have to spend the night.
Okay. Okay. Thank you so much. I know you have to take a break. Thank you so much for being with us today. Thank you.
Thank you. Thank you all very much. I appreciate it.